So, you've been dispatched to an apartment complex for a 34-year-old female with respiratory distress. Upon arrival, you found the patient sitting up on the couch in a kind of in and out tripod position. She appears alert, but she's in obvious distress. Basically, she states she used her inhaler all day, but that hasn't been working. So, her physical exam is significant for she's basically anxious. She refuses to kind of lay back in a stretcher or on the couch. She's CO times 4, GCS 15. She's tachycardic. She's got a bounding pulse with diaphoresis. Respiratory wise, she's in obvious distress. She has diffuse inspiratory and expiratory wheezing and just general poor air movement. So your partner obtains the following vitals. She has a heart rate of 120, a blood pressure of 154/70, a respiration of 34, and an SpO2 of 92%, and that's on room air. It's then that she informs you that she's been admitted multiple times, including to the ICU for asthma, and then she's actually been intubated twice. So I don't know about you, but to me, this case just screams asthma exacerbation. So here, our working diagnosis is an acute asthma exacerbation. So let's talk about that. So asthma is a heterogeneous disease characterized by chronic airway inflammation and variable expiratory airflow obstruction. That generally produces a wheezing, shortness of breath, chest tightness, really plus and minus a dry cough. Heterogeneous just means that it has several etiologies. So asthma can be classified as intermittent, mild persistent, moderate persistent, or severe persistent, kind of chronically. But classically, what we care wise is defined as intrinsic or extrinsic asthma. And the difference being intrinsic is a non IgE mediated asthma, whereas extrinsic is similar to kind of an allergic reaction. Um, Basically, it's atopic or IgE mediated, very similar to like anaphylaxis. No one really knows what causes asthma or why some people have it and some don't. Asthma involves a lot of complex, kind of underlying genetics with several potential triggers. Things like allergens, viral respiratory infection, sinusitis, exercise, inhaled irritants, strong odors, medications, GI reflux. And actually, going back to the medications, the big ones are like NSAIDs, aspirin, beta blockers, those kind of three of the big ones specifically. Cold exposures or changes in humidity, strong emotions, endocrine disorders, animal exposures. There's several things. And basically, all these things, for some reason or another, cause airway inflammation. But not, why that is entirely understood. So, evidence suggests there's an important role for Th2 cytokines, namely those who like biology. For those who like biology, these include interleukin 4, 5, and 13, I think. Um, and those are associated with the production of IgE reactions. This is probably why IgE mediated asthma, or the extrinsic kind, is by far the most common subtype of asthma. And essentially, what happens is you get this trigger, right? And you get this trigger, and that causes a non immunologic or an immunologic response. So you get this cytokine release. And then inflammatory cells kind of get, or inflammation, inflammatory cells, all this stuff gets recruited in the airway. And you get this big release of inflammatory mediators. And this is what leads to the bronchoconstriction, and then the airway hyperresponsiveness, mucus hypersecretion, airway edema kind of stuff that we traditionally associate with asthma. And this ultimately causes a decrease in max inspiratory flow rates and then airway obstruction, essentially, which is what is responsible for all the physiological consequences of asthma. Namely, the big three are hypoxemia, an increased work of breathing, and then air trapping. From a hypoxemia standpoint, you get this narrowing caliber of the airway lumen, and that causes hypoxemia in two kind of different major mechanisms. One, you get this increased airway resistance to flow in the conducting airways. So you get this uneven distribution of ventilation to the alveoli. And then this is really the principal cause of hypoxemia. And then this is partially compensated in a way by hypoxic vasoconstriction. And then, like, usually what happens is the VQ ratios actually remain abnormal. So then you get this um, as the secondary kind of cause of hypoxemia, this right to left shunt. It's less common, and basically it's caused by atelectasis of distal lung, or of lungs distal to the airways, basically being completely occluded by mucus. It's not the principal cause of hypoxemia, but it's a contributing cause. When we talk about the increased work of breathing, in an acute exacerbation, you have all of these, basically every respiratory muscle expending this increased energy. And that generates, large changes in pleural pressure to overcome airway resistance. And there's this discordance between respiratory effort and then the change in thoracic volume. So basically, you're not getting as much bang for your buck in an asthma situation, and you're breathing faster and heavier. And you get this sensation of dyspnea and then the central drive to increase ventilation, um, even if your O2 is okay, and you get this fatigue, right? And that fatigue, basically, if the airway resistance increases rapidly or sustained really in any way, um, you get tired, right? Because you're breathing really hard. And we kind of already put a lot of effort towards breathing, and now we're putting a lot more effort towards breathing. And this can lead to being tired, right? And then especially with, once you get into kind of the throes of hypoxemia, you get inadequate O2 delivery to these muscles, and that kind of makes it worse. And then when we talk about air trapping, which is what we traditionally associate with asthma, that's due to the increased work or there's you get this, increased work of breathing with the obstruction, right? So you get this, inhalation. Inhalation's an active process, right? So we can breathe in okay because we can overcome resistance by sucking air in, right? And then when it comes to expiration, which is the more passive process, your airway is prematurely closed during the expiratory phase and it gets this dynamic air trapping. And that air trapping can lead to hyperinflation. And this is why patients can usually breathe in okay. It's breathing out that's more of the issue. It's an air trapping disorder. Other than that, once you cause hyperinflation, you can get increased intrathoracic pressure, causing cardiac performance problems. You can decrease right ventricular afterload. You get decreased venous return, decreased cardiac output. You can get this circulatory collapse, and that's why asthma patients can die and become like hypotensive and stuff like that. So, asthma exacerbations are largely a clinical diagnosis, meaning all you really need is a history and a good physical exam with some vitals. The things you really want to ask about from kind of a historical perspective is if they have a history of asthma, they have a recent history of poorly controlled asthma specifically, if they have a history of prior near fatal asthma, so like this patient does, prior intubations, like this patient's had two, or different ICU admissions, complaints of severe breathlessness or chest tightness, difficulty walking more than 100 feet, those types of things can suggest worsening asthma. Patients are somewhat better judges of severity than us. So ask the patient how this is based to their baseline asthma, right? This isn't usually the first time they're dealing with it. And then, if they have history of cardiopulmonary disease or any other like coexisting problems, obviously things can all add together. So when we talk about physical exam and vital signs, the things that we really care about from a symptoms perspective, we care about cough, right? Whether it's dry or productive, we have dyspnea, wheezing, chest tightness, and then your typical findings of tachypnea, tachycardia, wheezing. Wheezing's tough, right? Because it's not actually an indicator it's not an accurate indicator of severity, and it can actually just be completely absent in severe obstruction. So plus or minus wheezing, prolonged expiratory phase, and that's kind of the hallmark, right? You can breathe in okay, you can't breathe out okay, so it takes longer to breathe out than normal. And then you can get hyperresonance to percussion, which I don't think anyone does in the field anyway. So then we can kind of take the subset of asthma where they have this, really severe disease. They're very severe asthmatic or a bad exacerbation. And these are the patients who only speak in a few words. They have poor air movement. They're using all of their accessory muscles, which, accessory muscle usage in general reflects diaphragmatic fatigue. And then, the scalenus area and the sternocleidomastoids up in the neck are really the area we're going to focus on for asthmatics, but it could be any, accessory muscle usage. Heart rate over 120, respiratory rate greater than 30. You can get pulsus paradoxus, which is greater than 12 millimeters drop in systolic blood pressure during inspiration. And that actually has a correlation of, um, sorry, Jacob, you're going to have to edit that part. I can't think of what it's called. You can get silent chest, you can get diaphoresis, you can get this inability to recline on a stretcher, you can get paradoxical respirations, heralding, impending respiratory failure. There's cyanosis, which is actually a really late finding just before respiratory arrest. Altered mental status, and actually the altered mental status is usually due to hypercapnia, and that's another one that ultimately or often reflects impending respiratory failure. So then there's signs and symptoms suggesting acute failure, like this patient's obviously not doing well. And the big things for me are fatigue and exhaustion, altered sensorium, worsening failure or failure to improve to adequate treatment. So like you're giving nebs, you're giving steroids, you're giving epi, you're doing all of these things and are not getting better. And then their SaO2 or SpO2 less than 90. So what about end-tidal? I get this question a lot. So what about the end-tidal CO2, right? What does that look like in an asthmatic? And turns out the answer kind of depends. So this is what we're traditionally taught, right? You get this shark fin waveform. And remember, always print this out to interpret it. You should always print out your end title. You shouldn't look at it on the monitor because it can actually look kind of different than when you print it out. So print it out. Anyway, so while this is often, the waveform it looks like due to uneven emptying of the airways with that obstruction, what does the number look like, right? What's the capnometry look like? So we have capnography, which is the graph, and capnography, which is the number. Capnometry, which is the number. And really that it depends, right? And it depends on shunt and VQ mismatch and all that other stuff. Remember that end-tidal CO2 isn't the same as PaCO2, which is what we actually care about. Like that's what you measure in a blood gas. It's an approximation of it. And there's always a gradient due to dead space. So, for example, in a modest obstruction, right, you can get this increased ventilatory needs or meets this increased ventilatory drive that meets or exceeds the level required to maintain normal ventilation, right? So you'll get normal or slightly even below normal PaCO2. Um, and keep in mind these are all based on PaCO2 values, not end-tidal CO2. End-tidal CO2 can approximate these things. In moderate to severe obstruction, that shortness of breath becomes more severe, and then you get this intense CNS drive to increase your respiratory rate or tidal volume, and that's when you start to get lower than normal PaCO2s, and you'll get this respiratory alkalosis to try to compensate. And then eventually, in severe or prolonged asthma, you get this high minute ventilation that can't be maintained anymore, right? The patient's getting tired, and that's when our alveolar ventilation starts to decrease, and it can decrease pretty dramatically, especially in the elderly. They can kind of fall off that cliff. So basically, normal, you got climbing, hypercapnia, and then this acidosis, PO2 greater than 40, right? Or you get normal or high PO2 and severe exacerbation. That's potentially like this really ominous finding. All right, so now let's talk about management. So, first, goals of management. Really, the problem is obstruction of the airways due to inflammation, right? And the goal here is to avoid intubation and provide supportive care with rescue medications, basically until steroids can work, right? Corticosteroids reduce inflammation, and they're kind of the cornerstone of asthma treatment. But they take 4 to 6 hours to work. So we need to buy time and use rescue meds in the meantime. So the goal of those meds is really to increase the airway size, right? Even really small amounts matter. Basically, this equation here is the Hagen-Poissy equation, and it describes airway resistance. So it shows that relatively small changes in the radius of an airway have a really huge impact on resistance, right? Because that R at the end there, after the pi symbol there, you have that R to the fourth power. That R to the fourth power is the radius of the airway. And being to the fourth power, really tiny changes make really big differences if you know anything about math, right? So, for example, anything to the power of is just it multiplied by itself that many times, right? So, like 2 to the fourth power is 2 times 2 times 2 times 2, right? So, 2 times 2 times 2 times 2 to the fourth power is 16. So, what's 3 to the fourth power? That's 81. So, it's 4 to the fourth power, 256. Right? So just going up by one, these really small changes in that radius can make profound differences when it comes to your patient's ability to breathe out. Small changes make really big difference in air movement, and that's kind of an important thing to keep in mind. We're not looking to completely reverse their disease. We're looking to get enough for them to breathe better, right? So when we talk about the treatment of asthma, we'll use kind of an ABC approach here. Not that you have to follow this linearly, because sometimes you don't. It just makes it easier to talk about. So let's start with A for airway, right? So you need to ask yourself, do I need to secure her airway? And then really, will this help her pathophysiology? Is this going to help her in any way? So We don't want to intubate these patients, right? You want to avoid intubating asthmatics at all costs because most of the time, one, they maintain their airways fine, and then that ET tube will increase the pressure in their chest even more, right? It'll make it harder to get air out. Think about it. Even an 8 ET tube is pretty small, it's pretty narrow, and these patients are a mess to handle on a vent anyway. Now we take them, you know, already struggling to breathe, make their airway even smaller, and then not let them passively breathe out or actively breathe out anymore. Um, it can be a complete disaster with these patients on vents and with their airways, and really the solution here is to not intubate them at all costs. With that said, sometimes you have to, right? The patient's tired, they have severe altered mental status. Sometimes they kind of force your hand, but that's kind of a more advanced discussion for another day. So next we have breathing. This is obviously kind of the bread and butter for this call, right? Asthma at the end of the day is in fact a breathing problem, right? So first we have oxygen. Um, some of these patients can be hypoxic, and treated with beta drugs may initially worsen that hypoxia by exacerbating VQ mismatch. Oxygen improves VQ mismatch, right? It's the dominant cause of hypoxia in asthma. The PO2 is usually increases readily in response to low levels of O2, right? So these patients actually usually get better with like 2 to 4 liters a minute. You don't necessarily have to have an on breather, even though that's what I pictured. Studies show titrated low flow O2 may have better outcomes than the routine use of high flow O2 in asthmatics. They tend to respond to oxygen relatively well. And then obviously the goal is to avoid hyperoxia, just like anything else. The mainstay of treatment, really, though, is albuterol or salbutamol for you non-American folk. Same drug. It's a beta 2 agonist. Usually it's 2.5 milligrams and 2 to 3 mLs. Then you give that in a continuous nab. Usually anything 15 to 20 milligrams an hour is safe. And these are really the first line agents in acute exacerbation. They have less than a 5 minute onset. They promote bronchodilation by increases something called cyclic AMP. And then it may also modulate receptor release from mast cells and basophils and promote, microcirculatory clearance, ciliary clearance, and all that. But the primary affects the small airways, right? Those smaller peripheral airways. It works by opening them up. Next, you have ipratropium bromide or Atrovent, right? And this is an anticholinergic. There's this like weirdly held misbelief that the goal of this is to dry secretions with it, and that's not the case. Um, it's also a bronchodilator, just kind of in a different way. So it's less effective and slower acting than the beta drugs, but it has a really low incidence of side effects, and generally it's given with the first few albuterol nebs. So you can give them together in the same nebulizer. It's got like a 30-minute onset. It's got like an hour to 2 hour peak effect. And basically, what it's going to do is going to promote bronchodilation by inhibiting vaguely mediated vasoconstriction or bronchoconstriction. Sorry. Basically, it's a competitive agonist for acetylcholine at the postgangliotic parasympathetic effector cell junction, right? So it decreases cyclic GMP and causes bronchodilation. If you don't know what any of that means, that's totally cool. All it does is it's a bronchodilator. It acts as a bronchodilator, just like albuterol, but in a different mechanism. So you're just trying to open those airways up in a different way. Now, as a side effect of that, you can get a drying of secretions, right? It is something that can happen just because turns out mucus production is also acetylcholine mediated. So by drying up all that acetylcholine, you're going to dry up the mucus too, but that's not why we're giving it. We're giving it for bronchodilation. And this usually affects those like middle airways, those larger airways. Finally, we got our methylprednisolone or our steroids, right? Dexamethasone, whatever steroids you carry, right? And this is believed to produce their effects by limiting the recruitment and activation of those inflammatory cells, right? So this kind of hits asthma at its start. And basically, it interferes with kind of the mechanism and metabolism of that and synthesis of leukotrienes and prostaglandins and stuff like that, which decreases inflammation. And then it can also increase the responsiveness of beta adrenergic receptors to airway smooth muscle. So it can help with stuff like that. But that's like a kind of tertiary effect. Basically, we're taking it to decrease the inflammation. And asthma, as we remember, is an inflammatory problem. The onset of steroids is like anywhere between like 3 to 4 hours, sometimes more. It's very variable, with the peak effects in like 6 to 12 hours. So basically, early administration. So if it's given in the first hour of the exacerbation, results in fewer hospital admissions and a lower rate of relapse after discharge. It's actually the principal therapy in asthma. right? And then its underuse is believed to be an important cause of fatal asthma in several different, studies and stuff like that. So it's, you know, I hear oftentimes like, oh, you can get the steroids and you can, but whatever, they're not going to do anything for us. Steroids are actually really important in asthma, and getting them on board within that first hour is very important. And turns out we are usually in that first hour. So get the steroids in. Now, should this be like, give this before albuterol? No, but get your steroids in. It should be a priority. Basically, what I do is I administer it to those who, show minimal or no improvement after the initial nebs, right? If I give you a neb and it's not helping, I'm going to give you steroids. Or, I'll also give it to like anyone who's currently taking steroids or recently discontinued steroids. So if they had like a recent hospital admission or stuff like that, if there's signs and symptoms of severe obstruction, so if their heart rate's really high, you get pulsus paradoxus, those things. Asthma with a history of respiratory failure, a really prolonged asthma attack that's been going on for like 12 hours. Those are all patients I give steroids and kind of prioritize giving steroids to. Um, so we generally carry the IV route. However, the oral and IV route are considered equally effective. So if you only carry oral route, then go for that. 99% of the time in EMS, we're going to give it IV or IM. This can be given IM as well. And then a lot of services will carry methylprednisolone and hydrocortisone, especially in the US. Keep in mind that methylprednisolone is the parenteral drug of choice. It's more potent than hydrocortisone. This is the one that we'll use in respiratory preferentially. If you only carry hydrocortisone, that's fine too. All right, so C for circulation. Get a line or two if these patients are sick. Then we can consider a fluid bolus here, right? The goal is euvolemia, not hypervolemia. A fluid bolus and then followed by some maintenance fluids isn't generally a bad choice. You can do even like a 30 ml per kilo kind of a fluid bolus. These patients can be volume down, especially if they've had a prolonged attack. So administering fluids early can be helpful. It'll also help reduce post RSI hypotension if you ever have to like go that route as well. Is this a priority? No, but it's something we can consider, right? As we breathe, we're breathing out water. That's like when you go outside in the cold, you can see your breath. You're breathing out water, and if you're breathing really hard, like in the case of asthma or shortness of breath, or from any other cause, really, you're breathing out more of that water. It's called intrinsic loss, and then you're worsening your intrinsic loss in an acute exacerbation. So they're losing a lot of fluid. So you always keep that in mind. And we have adjunctive therapies. And these are your beta adrenergic drugs, your more generalized, non-selective versions, right? So you have epi and terbutaline are the two big ones. So there's epi 1 in 1000 or terbutaline. So epi 1 in 1000 is a non-selective alpha and beta adrenergic agonist. Basically, it's effective with both A and B, but the B predominates, right? So it's really effective, or can be really effective in your severe asthmatics by opening up those bronchioles. You can give it sub-Q, IM, IV. Usually I just give it IM. And then, I'll give 1-2 doses, and after 2 doses, I start an infusion. So you can always do like an epi drip. Obviously, follow your local protocols. Don't listen to the random person on the internet, but it's something that can be done. And then terbutaline, 0.25 milligrams is usually the dose, I believe, and that's given every like 20-30 minutes up to 3 doses. I think that's what we're supposed to do. But obviously follow what you're supposed to do. It's more beta 2 selective than epi, and it has a longer duration. But studies head to head between the two haven't shown, superiority over epi. So they're considered equivalent therapies. They're just, they're more systemic beta drugs. So the goal is to do the same thing as your albuterol, but instead of inhaled, you're giving it through a vein. Next, we have mag sulfate. Mag's an electrolyte, obviously. There's like a really complicated mechanism in mag, and no one really knows how it works. Basically, magnesium has like 300 different roles in the body. It's involved in nearly every physiologic system. So it's a physiologic regulator of intracellular calcium influx. It's basically muscles need calcium to constrict. Decreasing calcium entry into the bronchial smooth muscle cells can cause bronchodilation. And that's really a guess. We're not quite sure how that works, but that's what the current thought process is it messes with calcium and leads to decreased constriction that way. It also prevents histamine release from mast cells, which can be a problem in asthma with that inflammatory response. So it may hit it there too. And then it also opposes the action of acetylcholine, so it might directly inhibit bronchial smooth muscle, kind of like Atrovent. But again, all of these are kind of postulated. No one really knows how this works in asthma or if it works, but it's always something we can try. It's one of those like kitchen sink approaches. Um, we use it relatively routinely in severe asthma where I work. Usually bronchodilation is observed like within like 5 minutes post administration. And that's where people like you give it and they're like, oh, it worked really well. That's awesome. And the patient doesn't do well again. And it's because it disappears really rapidly, right? So it's important to continue with the treatments and stuff. But you can get like this weird lull, like the patient starts to get better almost immediately and then they go right back to it. So it's really only a temporizing measure, at least in my experience. But that might help reduce the need for like intubation, right? It can still be helpful. And usually the dose is usually 2 grams, 2 to 4 over like 10 to 20 minutes. Obviously, follow your local protocols. And then finally, for an adjunctive therapy, we have non-invasive ventilation, so CPAP or BiPAP, right? And the goal here is to decrease the load on those respiratory muscles and improve oxygenation. And non-invasive, just like in pretty much any other therapy in asthma, also it can prevent the need for intubation. Um, you know, the patients who will most likely benefit from CPAP are usually those with like high work of breathing, PCO2 less than 45, or a PO2 less than 45. Someone who's alert, cooperative, just like anyone on CPAP. Someone who's hemodynamically stable, right? Because we don't want to like have someone who's super hypertensive and throw them on CPAP and increase that thoracic pressure and decrease the preload and stuff like that. So hopefully someone with like a minimal cough, no vomiting, that kind of a thing. Obviously play it by ear. Depends on the patient, right? Just be conscious of, patients who shouldn't be on CPAP. Usually you would do, if you have like a CPAP, you can, between 5 and 10, or if you do BiPAP, like an inspiratory pressure of like 10, EPAP of like 5, start there and adjust from there. Usually you'll adjust your inspiratory pressure. Don't adjust both at the same time. But if you just have CPAP, that's fine too. Technically, the benefit in asthma is shown mostly in BiPAP, but CPAP's probably okay. All right, so let's get back to the case. So we started on a duaneb, which is the ipratropium and the albuterol together. We do that in the house, and then we get her outside. And then when we get her out in the truck, she got standard IV monitoring. We placed her on BiPAP for respiratory support. We didn't stick around long on scene. We spent like a couple minutes, and she ended up getting an EpiPen en route. Then we hung mag. We gave steroids, and then gave her some more nebs. The intervention seemed to help. So by the time she got to the ER, she was actually doing okay. Not great, but okay. She ended up staying on the BiPAP. She got continuous nebs and an epi drip before kind of settling down, and then ultimately being admitted to the ICU again. Where fortunately she was discharged a few later. She never had to be intubated or anything, and was doing well. I've actually picked her up a couple more times. So that's it for today. Thanks for tuning in. Feel free to leave any questions in the comments. I'll try to respond to them soon. But until next time, thanks for watching.